No, that's perfect. Thank you so much. We can get started. And again, thank you for being here.
Of course. Yep. So I'm very excited to be here. Again, I'm pretty sure mostly all of you know me. Dr. Shihadeh, former attendings at Sinai, recently left Sinai. So I will be talking a little bit at, no, wait, hold on. Okay, great. I will be talking a little bit about structural racism in the healthcare system, particularly focusing this lecture on the treatment of African or Black patients in the hospital or in the healthcare system. Obviously, structural racism exists towards many other minorities as well, but I will be focusing this lecture particularly on that one for the treatment of Black patients. This whole lecture, sort of, me and Dr. Arhela started doing these sort of combined lectures after we started talking a lot about the disparities that we started to see and experience firsthand during the first COVID surge. So, I mean, it was a very tense times between the Black Lives Matter movement, the COVID pandemic, and what have you. So, this lecture was inspired by those times, but I do think that there's a lot of benefit that many of us can learn a little bit from. This is informal, as you all know me. I'm not super formal. I'm not formal at all. So if you want to interrupt me and ask any questions, make a comment, make a statement, share a feeling, an opinion, whatever it is that you need, just feel free to unmute yourself. And we can, this doesn't have to be just me speaking. There are a lot of slides, but I'm going to, based on how this goes, we'll get through them. And like I said, please unmute yourself and feel free to speak. I'd love to hear your voices. So with that, we'll start. So the first question that I have, and many of you maybe know the answer to this one, is how long does it take for basic sciences to translate into medicine or practices or things that we do in our clinic or the hospital? Do you guys know, anybody has an idea of how long does it take from, a basic science idea to translate into practice? No one? Anyone? Okay. Let's see. Years, yeah, yeah, sure, yeah, years. That is very true. It actually could take upwards of a decade for somebody to, for an idea to become an actual thing that we practice. So, and the reason why I want to talk, I want you guys to remember that, because once we get into the lecture a little bit, I want you to keep that in mind. When we start talking about the history, which is, this lecture is mostly historical anthropology, which is what medical anthropology is one of my many interests. So we'll get to it. Okay, so we'll get started. So, in most of the textbooks that we see and that we have been taught in medical schools, our mentors have been taught in medical schools, most of the subjects of research at the time have been centered around men. Women, children, slaves, or particularly people of color, were excluded and referenced to as an extension to men, right? So we were not necessarily studied. We were just like, whatever applies to men will automatically apply to the rest of us as an extension. And we know slavery that took many forms over the span of humanity, but the one that I'll be referencing to in this lecture is the one that pertains to the slavery involving people from Africa. In 2020, the US Census estimated that 33% of the people in the United States identify as members of a racial ethnic group that is underrepresented. This is obviously a huge number. This number is only growing in the United States. Unfortunately, only less than 6% of research faculty are members of this group, and only 4 to 5% of participants in research are members of those groups that are considered underrepresented. So if you can think about who does research and who is actually participating in research and how this research is being produced, based on these numbers, we can just clearly see that there's a massive disparity. Everything that I have in this lecture comes either from CMS or the CDC websites, or the New England Journal of Medicine. So I don't have any inflammatory articles in here. Most of it is factual. And I have all the references at the end of this lecture as well, if you would like to check. So how did we even start to think about, or how did we even start to question the status quo of medicine? So what has happened that all of us started to look into if the medicine that we practice sort of inclusive of all patients, men and women and people of color? So, I'd like to think that the majority, women are revolutionary. I think we are the ones that mostly start to question things, and I'm very proud of that. In this 1977, the FDA had at the time recommended excluding women from phase 1 and 2 of clinical trials. So when we do these basic science research, the FDA said that women are not really smart enough, even if they consent and everything, to make any decisions regarding their bodies, and therefore we must exclude them from all, clinical trials that irrelevant of a drug. And believe it or not, some of these things were very silly. It could include drugs that are, pertaining to women only, that they still excluded women from these studies. We all know about the complications. I don't know if we all know, but thalidomide was a drug that was used, I believe, back in the 70s or the 60s. I think it used to be as a pain medicine. I don't know much about it, but unfortunately, this drug was only studied in men. And when women that were pregnant or planning to become pregnant consumed the drug, unfortunately, it led to many teratogenic effects, particularly limb defects. So once this became public knowledge, in the 80s, the NIH created a policy that encouraged researchers to include women in their research and their basic science research. It encouraged them, but it didn't really sort of force them to include women. Kind of said, you should probably do it so we don't end up with a case like thalidomide again. Unfortunately, in the and obviously that wasn't clear, that wasn't followed. In the 1990s, the NIH was investigated for its lack of commitment for enforcing that women and people of other ethnicities are included in the research. And in 1993, it became a law that women are to be included in clinical trials. Now, we're talking about 1993. Many of you guys were born probably before then. Many of us were taught from books that were written before that time, are using drugs that were, researched and approved into the market before that time or around that time, right? So this is just something to think about a lot of the things that we were taught and a lot of our old school mentors, the things that they have taught us, and many of the drugs that we use, and many of the complaints that we hear from our patients that don't necessarily fit into what the books say. Sometimes you wonder, is it because it doesn't fit into the book, or because the book wasn't necessarily inclusive of all these people that don't necessarily have the common complications or the common complaints that, the average patient has. I mean, one of the biggest examples that I can give you guys about this, and this we see all the time, is, our views about what angina and, heart attacks, since many of you guys love cardiology, come from this whole like clenching substernal chest pain, and that really comes from studying men in that era, right? We all know that women present with chest pain or with heart attacks very differently. So do Black people. But unfortunately, the only people that were studies for PCI and angina research and all of what have you were men, were particularly white men. And most of them presented like that. But unfortunately, the rest of the population, about 50%, which are women, don't necessarily have to have these issues. And, as you can just imagine, how could that lead into poor treatment if we're not necessarily familiar with what the textbook presentation is like? So only in the 1993 that it became a law that we had to include women in basic sciences. Unfortunately, this was not the case for Black patients. So it would be many, many more years. And I think we're still battling, this issue where, unfortunately, Black patients particularly, and patients from other minorities are not as included in the research, or are not as, the laws are not as, forceful at including them in the research. So let's talk a little bit about how we're treating our Black patients right now. And we're going to go into or over some statistics. You might find them boring, but I think they're very helpful for you just to understand a little bit, and maybe hopefully it helps shape the way you treat your patients a little bit more. Black or African American men have the worst health outcomes of any major demographic group, period. They receive lower quality care and services that include cancer, HIV, prenatal and preventative care. They're less likely to receive treatment for cardiovascular disease, more likely to get unnecessary limb amputations than any other demographic group, right? I mean, let that settle in for a little bit. We work in Harlem. A lot of our patients are Black or of African descent, even from South America, or as Black African American patients in the United States. And let's just think about that statement for a second. Sickle cell disease has received less attention than any other less common diseases that affect a single gene mutation. And the opioid crisis did not spread in the Black community. despite what many people believe, likely due to underprescribing of opioids in Black patients by physicians. And the good news, I guess good news or bad news, Black patients' care is better when the doctor is Black. And Black patients receive 34% more preventative care when the doctor is Black. Unfortunately, though, 4% of all doctors are Black, and less than 7% of recent medical graduates are Black. Despite everything, despite trying to sort of allow more equitable medical school entries, et cetera, only less than 7% of recent medical school graduates are Black. So there's still a huge disparity between the number of patients that we have and the amount of doctors. And clearly, they do better when the doctor is within the same race. So there's something to say for all of us here about how we're treating our patients, even though sometimes we might think we're doing the good thing. I think, unfortunately, many of us have our biases. And I think confronting our biases and talking a little bit about them potentially can help us, do better for all of our patients. So let's talk a little bit more about that. I'm going to skip through this, mostly about insurance. Let's talk about this. So 80% of African-American women are overweight or obese compared to only 64% of non-Hispanic white women. I mean, obesity is still pretty rampant in the United States. It's pretty bad. That's a number to compare to 64%, but it's still quite higher. 12% of African-American children have asthma compared to only 7.7% of non-Hispanic white children. And 42% of African-American adults over the age of 20 suffer from hypertension compared with 28.7%. And overall, Black people, whether men or women, live 6 years less than their white counterpart. So, there's something is off, right? We're not doing something right. Our patients our Black patients are not living as long as others are. This is a study this is a Medicare population study. Medicare has obviously probably pools of data from all over the country. They studied a group of 40,000 patients with atrial fibrillation, a condition that we all treat. And they found that Black people were 20% less likely to receive a DOAC. And the reason why I brought this study into focus is because this is something that we do. I mean, I prescribe a DOAC at least once a day. And they found that, Black people are receiving 20% less DOAC than others, even when they adjust for insurance, basically insurance coverage, which is to go to say this is not about the copay. This is not really about money, financial status, et cetera. We're simply not giving Black patients the DOAC. They are 20% less likely to do it than white patients, for example. And why is that? I don't know. Do we not want to take the extra step? Do we assume that they can't afford it? Do we? I don't know, but this is a fact, right? This is something that we as physicians are doing and contributing to. Let's see. The leading cause of death among African Americans is heart disease, cancer, and accidents. African Americans have the highest mortality rate for all cancers combined, compared with any other racial and ethnic group. These ones are pretty painful to say, but there are 11 infant deaths per 1,000 live births among Black Americans. This is twice the national average, right? So twice the national average of infant death. So these numbers are quite astounding. Maternal health, I would say, probably has to be one of the worst out of all these statistics. Black women are 2 to 3 times more likely to die from a pregnancy than a white woman. I mean, it's pretty high, especially in this day and age. Pregnancy-related deaths per 100,000 lives for Black women older than 30 was 4 to 5 times higher than white women in the same age group. Even if you adjust for college education, those odds do not change. They're 4 to 5 times more likely to have a complication or death than any, than white patient. This is pretty astounding. Unfortunately, most of these deaths are preventable. So this is not to go to say, oh, it's genetics, oh, blah, blah, blah. It's cardiomyopathies, it's PEs, it's hypertensive cardiomyopathies. These are all things that could have been screened that, unfortunately, again, we are not doing a good job with. Again, more about women's health. Black women are less likely to have breast cancer, but 40% more likely to die of it, right? 32% more likely to die of heart disease, 71% more likely to die of cervical cancer, and 243% more likely to die of maternal related complications. Why, right? Is the real, there are really a lot of big whys here. Why is this happening, right? And many of these statistics, again, done through CMS, adjust for college and income. So we cannot really say this is about access. We cannot really say this is truly about an inherent bias that somehow has been so deeply rooted in the practices of medicine that is leading to these things. I mean, women in general do have, unfortunately, poor outcomes. But then when you add the double minority issue, these statistics are quite disturbing, at least to me. I'm gonna skip through these. So the question is, why are we here, right? Why are we treating these patients so much worse than we are treating everybody else? I mean, I don't really think any of us is a racist per se. Any of us are out there like, oh, I'm gonna do worse for my patient today because I want to. I really genuinely do not think any doctor out there is truly waking up in the morning and saying, I'm going to treat my Black patients worse than my other patients, right? I don't think that's the case at all. Unfortunately, there are things, and we're going to go into those things in a little bit, that are just so ingrained into the way we were taught and mentored that are giving us these biases that are unfortunately translating to this. And whether you like to believe it or not, it's up to you, but these are the facts. And the more we talk about them and understand why are we doing these things, potentially the way, it's the way to change it. So we'll start with this question, and we'll answer this question at the end of the lecture. And the question is, you don't have to answer me right now, but do Black people have thicker skin than white or light-skinned people, right? So I want you to keep that question in mind, let it simmer for a little bit, and we'll get back to it at the end of the lecture. Okay, so why is it that we are treating these patients differently? I mean, what is this notion of race, right? I wanted to talk a little bit about this for a second, because I wanted to sort of question a practice that all of us do, which is, this whole way of, reporting an HBI. Maybe I am a little bit old, but the way I was taught to report an HBI was age, sex, and race. 52-year-old female, Black female, white female, Hispanic male, whatever, right? Why was it so important for us to talk about race, right? Is it because, is race something that is automatically going to translate to a particular biological issue? And this takes us to the question of what is race, right? Is race something that is biological, as in if you are of a particular race, then you are genetically different, versus, is race something that is, that you acquire from your environment? And really that really, it is actually what defines a race. There are different schools that define the race. Some of them, follow the biological, which unfortunately we fall into. We think of race as a biological factor, right? We think of race as genome, as DNA. Unfortunately, we've never really sequenced a race DNA fully, right? We have like mutations and particular genes, blah, 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 that affect certain populations than others. But we've never really been able to say that actually, I don't think we can say that the genome of somebody who's white versus Black versus Hispanic is completely different. The other school of thought is that race is a social construct. Basically, it really depends on where you're from and the history and politics and what have you. The current way of defining race in the United States of America is that your parents, when you are born, define your race. So it's not something that you are, nobody is just sort of like looks at you and says, oh, you look, I don't know, Asian today, so we're going to call you Asian, right? Your parents can give you the race, and your parents can give you any race that you want, right? You could be Black and they call you white, right? That's the race that they define in your birth certificate. So again, we discussed these things. So that's that. Yeah, we discussed these things already. Okay. Let's skip through all of these. And again, why is it so important to talk about the notion of race? Because we do talk about it every day. We do discuss these things on rounds. We do have patients that present, and we do talk about their ethnicities and what makes them more prone to certain things than other ethnicities. However, a lot of these things that we used to know are slowly being debunked. One of them being sickle cell. Used to be, widely known as a Black disease only. Only people from Africa, malaria protection, etc. But malaria is quite common in many other places in the world, and Middle Eastern folks, Hispanics, and East Indian people also can inherit sickle cell. However, it's because we only think sickle cell is a Black patient disease. We don't screen those patients, right? So a lot of these things that we know about race are slowly being debunked, mostly because human beings aren't, we're not purebred, right? People travel, people, breed amongst other races, and, we create races that weren't there, probably, genome races that weren't there, hundreds of years ago, right? So when we sort of like associate particular diseases with one particular race without having had truly and genuinely counted the amount of races in the world and sequenced every single one of them, which is probably an impossible task to do because there's so much breeding happening amongst complex human beings, then we miss diseases, or we label people with diseases that they potentially don't have because of our lack of knowledge. So I guess the next question that we can ask ourselves is that why is it that doctors, what incentives is that the doctors have? I mean, we all think of ourselves, went to medical school, and probably everybody even back then went to school, became an apprentice with a surgeon or whatever, because they wanted to help people, they wanted to do better, etc. But I think what we all have to remember is that, medicine does not operate in a vacuum. I think that, and this is something that even we see in this day, even at us as doctors, we are influenced by politics, we are influenced by the environment that we're in, and and therefore, unfortunately, even our views can be swayed based on the current situation that we're in. So let's talk a little bit about, let's visit some historical facts that I think that we can, really reflect on from our day-to-day practices, and and see how they relate to what we're going through right now. Between the 1880 and 1940, there was a large drop in fertility in women, period, right? Women stopped making babies, or as many babies as they used to make, right? Unfortunately, however, and again, I want you to look at the dates and think about them for a second. This is 1880 to 1940, right? Many of our mentors were probably taught from books that were written during this era, right? Remember, it takes years for things to translate from the books to the practices. So, but anyways, there was a drop in fertility of women, period, across all women in America. However, for whatever reason, all of the textbooks started pointing this, they said, oh, well, because white women, they wanted to become independent and go to colleges, but Black women, on the other hand, the reason why the fertility dropped is because venereal diseases were so rampant in them. And there were textbooks written about this, right? I mean, these are some examples of books written in the 70s. Talking about the rampant venereal diseases that were in Black women that were not in white women, because white women just wanted to be independent. However, Black women were just like these completely creatures that were unable to control themselves and desires at all, right? Obviously, this was completely inaccurate, and it was debunked about 20, 30 years later, where it's like, no, Black women did not have a lot of venereal diseases. They, just like any other women, especially when segregation laws were coming in, and or at least civil rights movements happened and what have you, where women were able to do more for themselves than before. Then women started having less babies because they wanted to become independent, just like anybody else, and it wasn't about that. But these books were written in the 40s, and books written in the 40s, taught in the med school in the 60s. Some of our mentors and mentors of our mentors went to school during that era. Do they have, do they really have that mentality, or is this something that they studied? And again, when you see something like this in the book and you study it, while you may not be a racist per se, but this is just something that sticks in your mind. This becomes a bias of yours because somebody said it. And when a lot of people are saying it around you, this is something that, especially that's the only knowledge that you were given, right? That's the only explanation to something that you were given, is that they have a lot of venereal diseases. So is it possible that you know, that this is why to this day we're not treating Black women in the hospital, you know, during the, you know, one of the most vulnerable times as well. We don't think they're worthy of having babies because we don't think that they should, you know, they have so many babies because they can't control themselves. Is this something that we're doing in, you know, with a bias? You know, given the history that we've had for, you know, pertaining to women's fertility. The next one is, you know, again, another one about women, you know, is, you know, the father of modern gynecology, which unfortunately I believe we still have the statue of at Sinai. You know, he experimented on slave women without anesthesia. He was trying to perfect a repair of vesicular vaginal fistulas that used to be a common complication. The statue was taken down. Okay, thank you for letting us know. Excellent, wonderful. That's a win. But you know, vesicular vaginal fistulas was a common complication that used to happen for women during birth. And you know, he wanted to perfect a method to sort of repair those fistulas, and he decided that he could do that on slave women. Unfortunately, without anesthesia, you know, these women went about 30 or so operations each without anesthesia. You know, in sort of an auditorium type situation where he would just like, you know, show people how to do the procedure. And once he perfected the procedures, he said that white women were too frail to undergo this type of procedure without anesthesia. So therefore they should go for anesthesia. But you know, he was comfortable doing that without anesthesia on his slave women, right? And is this one of the reasons why, you know, we don't treat our pain? You know, is this something that comes from that? We still to this day think that, you know, Black people don't experience as you know, their pain tolerance is different than white patients or patients who are lighter skinned. So, you know, many things to question here, right? And I, you know, and again, and I say this because these are mentors of our mentors, and these are things that were, you know, ingrained in our minds early on in our training, that sometimes makes you wonder what else is in there that we haven't realized yet. Many of you are aware of the Tuskegee Syphilis Study, which essentially was, and if you don't know, it's important for you to know because it's something that affects us to this day. In 1932, the United States designed a study to observe the natural progression of untreated syphilis. Right at the time, I think the treatment was mercury, which obviously we know doesn't work, but that was the standard of care back then, is that you give people with syphilis mercury. But they decided that they were going to take, you know, 400 Black men from Alabama. You know, and again, this is nobody. No, there were no slaves at the time. You know, everybody was supposed to be a free person here, right? Free, you know, free-willed individuals. And not that race, you know, slavery was okay, but you know, this was during everybody was in no slavery here. You know, but they decided to take 400 Black men, and they decided to, you know, give, you know, that the ones of 200 had syphilis and the other 200 saved as a control. You know, the one were going to be treated and 200 were not going to be treated. And they basically let them fester. They let them transmit it to their families. They let them have children with it. And only in the 1969, and then the CDC, okay. The CDC examined the study in 1969 and decided that they're going to continue it. I mean, the CDC, nobody likes the CDC anymore, but even so, in 1969, they decided to examine the study and they said, you know, I think this is a great idea. I think we should probably continue to see what happens to these 200 people and their children, right? But then a media leaked, you know, somebody leaked that this was being done, and they decided to terminate the study in 1972, right? 1972. I mean, I'm pretty sure people that we know right now were practicing at the time or were in school at the time. I mean, this was happening very, very recently, that we thought this was okay to be done. Because of this case, you know, an IRB became mandatory for any human experiments. So this is why we have an IRB now, is because doctors, as much as we all like to think of ourselves as like, you know, out there, you know, for the good of humanity, we're not that great, right? We're just human beings, and we are not, you know, we are not far from flawed. And when given the opportunity, we will abuse our powers. And this is a great example of that. But, you know, this is something that happened quite recently. And, you know, basically we experimented on poor Black people. And, you know, we were, you know, I don't know what they were doing, the details of the study exactly, whether they were doing drugs or not. But, this came out in the 70s. Many of the patients that we have were born way before then, right? And they know about this. And, do you think that they're going to trust the medical professionals now, especially if the medical professional does not look like them, right? I mean, do we really blame them when, somebody particularly could have had a family member part of this, or a relative, or, it doesn't matter, but it was targeted at Black people. So it is not really unreasonable of that group of patients to not trust the medical professions, right? This became an issue again when AIDS became rampant. Black patients stayed far away from doctors as possible because they did not want to be experimented on. Many articles, many newspapers, they were talking about how Black people really thought AIDS was engineered to kill them. I mean, these are things that we heard during the COVID, during COVID times. It was engineered to kill us and wipe this out, da, 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 da. But this was also the case during the AIDS pandemic, right? Black people truly thought, there were headlines in newspapers, which I should have taken clips of, is that it was engineered to kill Black people, and it was killing probably more Black people than others, because Black people also refused the treatment because they thought they were being experimented on. Nobody wanted a repeat of Tuskegee, right? So they were not going to subject themselves to this, to all the treatments that was happening at the time. I mean, can we, and we can obviously draw a lot of similarities to what has happened during the COVID pandemics. I mean, a lot of the patients, particularly from, Black patients, patients of minorities, they did not want the vaccine, did not want to participate in the vaccine research, and they did not want the vaccine, mostly because they were afraid that we are experimenting on them. And, again, knowing the history, you can't really blame them. I mean, we know the research, we know everything, but again, people just don't trust doctors as much as we like to think people trust us. But that, that history is still there, and it's still quite new. At least I think it's still quite new. Selective targeting and osteoporosis. When going through school, at least during the training, the folks that you really selected for DEXA scans or to screen for osteoporosis, because it wasn't really at the time very standardized, is that only thin, white, fragile female really had the highest risk of osteoporosis. Unfortunately, that was a study that was done that actually said that, the thin, white, fragile female, and that was sort of the stereotype for the highest risk of osteoporosis. Unfortunately, the study, later on, the study was questioned because the study forgot or did not account for weight, diet, smoking, alcohol intake, exercise level, and reproductive history. And unfortunately, what this did is that it decreased the amount of screening that we started doing to other populations. So if you were Black, if you're Latin, if you're anybody else who is not a thin, white, fragile female, then we assume that you don't have osteoporosis. Even to this day, my image when I think osteoporosis, I truly still think thin, white, fragile female, but in fact, that's not true at all, right? I mean, anybody can have osteoporosis, and it's really not based on your race, or it really based on smoking, weight, so many other things that go into it. But that is what I was taught, and that was what sort of was ingrained into my mind. And it's really difficult to change biases sometimes. Let's see a chat pop up. Let's see. And somebody, Ariella said, the Frax scale that was used to calculate a person's risk of fracture had race factored into it. Absolutely. Yep. And this, we'll talk about these algorithms as well later on. But absolutely, I mean, we've done a lot of ridiculous things that, when you really think about it, you're like, I have no idea, how anybody's alive at this point. But, they're still, everybody's still here. And again, I mean, everybody's like, oh, well, this was the 70s, the 60s, civil rights, da, 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 da. I mean, we think that we're so much better, we're woke, we're so much better than this. Unfortunately, that is not the case. So last year, during the whole COVID pandemic shenanigans that was happening, and I say during the COVID pandemic, I mean, I don't know if it ended yet, but I guess masks are no longer mandated. But anyways, the New England Journal of Medicine discussed the disparity in O2 monitoring based on questioning the research that went into developing the machines themselves. So somebody decided to look into the research that was done when, the pulse oximetry, the machine, that's a technology. I mean, whatever the company that you use, a different story, but the technology, which is the waves, the ultrasound, blah, 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 whatever, I don't know. But the technology that was created, the patient population that was used was a very heterogeneous population. were mostly patients of light skin color. And again, this is not about a race thing. This is really about a skin color or a skin tone thing, because it is about waves and ultrasounds and transmissibility and across tissues, et cetera. And unfortunately, they decided to run many studies to see if the lack of the variabilities amongst the, did I say heterogeneous? I'm sorry, it was a homogeneous population that they studied. So when they decided to run some studies to see if the fact that the original technology was done with a homogeneous patient population is leading to worse outcomes. And unfortunately, two large cohorts, two separate ones, noticed that Black patients had nearly 3 times the frequency of occult hypoxemia. Not to say that light-skinned patients did not, but dark-skinned patients had 3 times the likelihood of occult hypoxemia, meaning that you check the oxygen and the oxygen is normal. However, and this is what there was a study, essentially, they would check the oxygen, the O2 pulse ox, but they will also do an ABG. And, dark-skinned patients, Black patients, were more likely to have occult hypoxemia. Their O2 pulse ox monitor does not match the ABGs, right? And again, this was a flaw in the initial technology that was done because it did not take into account the heterogeneous population that this country has. So, I mean, could this have contributed to the many other COVID disparities that we have? Is this why Black patients were dying more? I mean, I think the verdict is still out on this one, and there's a lot of talk out there about this COVID disparities. I don't think there's anything, to be honest, I personally think nothing has been substantial enough for me to include yet, but it makes you think. I mean, were patients hypoxic when we did not know they were hypoxic, and therefore we didn't treat them faster, early on, et cetera? I mean, this raises a lot of questions. And then the last one, and again, I apologize, you should have had handouts sent, but this was taken, and I'm happy, in the reference to the article is at the end of the lecture. But this is a list of algorithms that use race as part of just sort of exactly like the osteoporosis one, exactly like the GFR. And many of these things are, many institutions are sort of getting rid of the race box, I suppose, in the algorithm, because we are slowly, and unfortunately very slowly, realizing that race does not necessarily translate to a biological difference. Many of these algorithms are CT surgery algorithms, some urology, some oncology. The one that pertains to us is the GFR, which many institutions are no longer using. But essentially, the GFR, when we used to calculate GFR, the race, if you are Black, you had to check a box, which essentially made your GFR or exaggerated your GFR, because this was done with the notion that Black patients simply had a higher body mass, muscle mass, right? So their GFR is high. We just assume that all Black people are just like these like super muscular, I don't know, like athlete looking people, right? And therefore, their GFR has to be higher because their muscle mass is just so much higher than the rest of us. And unfortunately, what this done is that Black patients just had a higher GFR. And if you really think about it, how does that affect us? If a patient had a higher GFR, you're less likely to dialyze them early, right? You're more likely to give them drugs that are potentially nephrotoxic but they don't go into that criteria, right? They're less likely to get on dialysis list early on, so on and so forth, right? So this was, at Sinai alone, and I can't speak for other institutions, we only removed, and the GFR is something that's calculated, during the labs. Like you don't sit down and calculate the GFR; it's just calculated for you. But only last year we removed the race from the algorithm that calculates the GFR. So only last year, Sinai, and again, I'm not pointing at Sinai, but just in general. Only last year, we removed the race, and we said we are no longer going to acknowledge race as a factor in the GFR last year. So up until 2021, we still believe that Black people had a much higher muscle mass than the rest of everybody else, basically, right? And again, and who's to say who's Black? I mean, there are South Americans that are just as dark as African patients, or Indians are just as dark as African patients, but unfortunately, it was just, African American. That was the checkbox. It wasn't Black, it was African American, right? Which again, is silly, because again, that just clearly shows you that we have such a poor understanding of what race is, and we are essentially using color and facial features to determine the race, which is a pretty superficial thing to do. So again, we talked about these things. Some of the things, the modern day issues that are happening right now. I don't know if you guys have heard about this, but Serena Williams almost died giving birth to her second child. So she's known to have a hypercoagulable disorder and had a previous PE in the past, right? Past medical history of a pulmonary embolism. She went for a C-section for her second child. And during, after the C-section happened, she had just had her belly cut open, had the baby out, she's sutured, she's in her room, and she started telling them, I'm experiencing chest pain and I do think I have a PE. And they thought, they were like, oh no, you're anxious, yeah, There was a whole documentary about it. And eventually she sort of had to force the doctors to sort of take it seriously. And the first step that they did, they got a Doppler of her lower extremities, which didn't show a DVT. And this took about a day or two before they officially diagnosed her PE, when she started having the symptoms before. And unfortunately, they had to start heparin on her, and she had just had a C-section, so she almost bled to death. It was like a whole mess, big of a mess. But again, Serena Williams is probably one of the most famous Black women out there, period, worldwide, right? And this is somebody who still potentially could have died of a preventable disease, right? PE, known history of PE. She wasn't on aspirin before. She wasn't on She was not put on heparin injections before or during her pregnancy, despite that being the standard of care, right? She wasn't put on heparin during her pregnancy. And even when she had symptoms she's experienced before, she was still taken lightly, right? So this is, unfortunately, these biases that we have aren't about money, education. This woman is as famous as it gets. And unfortunately, she still had to go through this horror with doctors during her pregnancy. The Department of Medicine at Harvard Hospital, right? Mass General, Harvard, big name. They decided to form a committee in 2017 that went on, I think, for a couple of years. And they wanted to look at the structural racism practices that they've had. And they published about how admissions to the cardiac service at Mass General Hospital, Harvard, big name, was predominantly white. They acknowledged that, right? I'm sure this was a very difficult article for them to publish. I'm sure many heads were chopped off, but they said, they determined that their cardiac service was basically only admitting patients with cardiac issues that if they were white to the cardiac service, and everybody else ended up on the medicine service. And not to say that we're not great doctors. I think I'm a fantastic doctor, but I'm pretty sure if you have a cardiac related issue, you should be with a cardiologist, because they probably will do a better job than I will. But unfortunately, their admission algorithm had a lot of biases into it. And unfortunately, they ended up, in a position where they had to, talk about it, they had to acknowledge it, and, they sort of made a lot of promises that they're going to do a better job in the future. But again, none of us are immune to this. It can happen to all of us. And I'm glad, I really am very happy to see, I think the New England Journal of Medicine has been doing an amazing job at talking about equity and race issues. But, to see a big institution like Harvard, sort of tackling this, head on, I think it's very inspiring. And this is very common. And, before I suppose we close, does anybody want to talk about an experience that, that happened to them, whether they were subjected to structural bias during a doctor's visit, or they've witnessed it? I've spoken for too long, so I would love for somebody else to say something. No? Everybody here is good? No issues whatsoever?
You can write it in the chat as well. Yeah.
Wait, I don't know if my camera is on because okay, well, I haven't noted so much here, but in Sweden, where I did my medical school, I did notice several times, especially in the emergency room, where or there was this one particular incident where a woman who came in, who was Muslim, wearing a veil, came in with abdominal pain, and the surgical attending there was like, oh, I see this all the time. It's like cultural pain, ethnic pain. She just wants like a letter so she doesn't have to go to Swedish class. And then like someone ended up getting a pancreas on her, and oh, something is up with my camera. Oh.
Yeah, I think it's facing the other direction. You should probably face it. Oh, there you are.
Okay, then someone ended up getting a live face on her in the end, and it was very high. And she was like admitted for pancreatitis in the end. But this attending apparently has, like, I told my friends about it, and they had like the exact same experience with her. So this was something that she routinely used in her assessment. And there was this like a notion about like ethnic pain or cultural pain that was very problematic.
Right. Absolutely. And you know, this was recently, it was published, actually, it was many articles about it in a nursing textbook, where it was like, you know, something like Latin patients are, you know, experience too much pain versus Asian patients, not enough pain. Black patients seek too many pain. It was literally like written out that way. And then like Muslim patients, they don't want to talk about pain because God is the forgive. It was like some crazy verbiage that was used in a nursing textbook that was still being used in nursing schools. I think this was a couple of years ago, where it was like, you know, the whole, you know, they had to like pull the books from the shelves because the book was just insane. And it was, again, a lot of this like ethnic pain, you know, this is related to your ethnicity, your background, et cetera, but not necessarily validated in any way or form. Yeah. Let's see, I see the chat. What did you guys just post?
Yeah, so Kirtana had her question, but we just posted an article of the case that you were talking about, the nursing book that was pulled, in case people are interested and want to read more about it.
Absolutely. You know, this is a story that I've shared, but I will share again because, you know, we see this, you know, I'm very sensitive to this, you know, I'm almost a little too sensitive sometimes, you know, and not necessarily a very sensitive person per se, but sensitive to the topic. And, you know, this is something that I've witnessed a couple of years ago with one of our, you know, again, amazing team of residents that I had that was just top notch, no criticism of that team whatsoever, that we've had a patient that had come in and, you know, in her history, that she's had a history of like cocaine use, you know, I think that was hypertension, non-compliance, etc. I mean, she did have a personality disorder for sure. She's a little over the top, but she came in because she was weak. She said she couldn't walk anymore and she had a headache. So, you know, she came in and they did like, I forgot what they did. They did like some labs and like, you know, they did a U-tox, which was negative, but her blood pressure was like 200 and something. So they decided to admit her for uncontrolled hypertension due to non-compliance, right? So anyways, the next day, you know, this was admission during the call period. The next day, you know, the team is presenting the patient. The patient is a tough historian. She didn't give any history, but she can't walk, but she's walking. You see her walking. You know, U-tox was negative. She's got a history of cocaine. So, you know, so anyway, so we're talking, we're going through the differential. Her blood pressure at the time was still about like 200 or so. And, you know, talking about it, I was like, so what is the differential? They're like, oh, you know, weakness likely to cocaine, uncontrolled hypertension. I was like, wait, what? But she's cocaine negative. Like, what are we talking about? He's like, yeah, but, you know, it doesn't have to show up. I was like, yeah, but if it's negative, that means she probably hasn't used in the past few days, but her symptoms are happening now. So, you know, after, you know, and I had to fight, and, you know, I don't know if many of you have rounded with me. I'm not somebody who's like, you must do what I say, my way or the highway kind of thing. I like to let people kind of like, okay, sort of do as you wish kind of thing, no problem. And I'm watching kind of thing. But on this one, you know, sort of we almost like butt-headed for a while. I was like, no, I think she's having a stroke. And her neurological exam wasn't really that exciting. She did have a little bit of weakness, which she was like, oh, but this hurts, that hurts. She wasn't the best historian. She could give you a good history where she's like, my leg feels heavy. My leg feels heavy. I'm not walking well because my leg feels heavy. But her maybe it was like 4.5 out of 5 on the right side. Nothing really like, you know, wow, like this is so like, you know, crazy. But her blood pressure was 200. She was saying her leg is heavy and she's hypertensive, you know, and she was like 48 or so. So I was like, you know, we need to get a head CT scan. And I was like, where's the EKG? And oh, I had CT. I was like, just do it. I was like, you know, she came in with a blood pressure of 200. She has a headache and she's saying she's weak. Let's just make sure she doesn't have a stroke. You know, but they're like, well, even if it's a stroke, it's cocaine induced. Well, yes, but the, you know, Utox is negative and the blood pressure is high and she's a hypertensive. Lo and behold, long story short, the patient not only turned out to have AFib with embolic stroke, multiple embolic strokes on the MRI after the first CT scan was positive, AFib, heart failure of 20%, ischemic cardiomyopathy. None of what she had was related to cocaine, right? She had ischemic cardiomyopathy, she had AFib, and she had heart failure with reduced ejection fraction. She had multiple embolic strokes. Now, fortunately, she didn't have any major like weaknesses, but think about all the things that went into for her to get the diagnosis. She came to the ED with a blood pressure of 200. She was given medications to lower her blood pressure, which for an acute stroke, that's not okay, right? She wasn't given a CAT scan. A stroke code was never called. Again, people were just, you know, blood pressure medicine, blood pressure medicine. When she was actually having an acute stroke, she was potentially going to be discharged without having to do, you know, understand where these strokes are coming from, you know, to understand that they're embolic. I mean, it was just messy, mostly because people looked at her and said, cocaine use. She was like a little over the top. Nothing out of the usual, I suppose, nothing too much, you know, just had a little personality disorder, but she was pretty consistent with her story. And unfortunately, she was labeled as a cocaine kind of patient. They just saw her, they were like, oh, you know, whatever, cocaine personality, blah, blah, blah. And they completely missed her symptoms. And is it because we just completely, you know, it was a bias, right? It's like, oh, just whatever, cocaine patient, you know, and unfortunately, this is somebody that would have potentially had many, many bad outcomes had it not been questioned and questioned well. But this is something that we all do. And, you know, I see it not too long ago, a very dear colleague of mine, again, patient hemoglobin was at 6. And, you know, last one was normal 2 months ago of 14. But the patient wasn't here with your hemoglobin GI bleed. They were here for like chest pain or some random stuff. And, you know, I had come on the service and the team was like, the plan is for discharge. And I'm like, well, what about the hemoglobin? Oh, I guess it's from CKD. I mean, the patient did have CKD, but the hemoglobin was normal like less than 6 months ago. So maybe we should investigate this. Oh, but the patient is literally, I mean, this is a sign out I received, you know, hemoglobin is whatever, you know, it's probably CKD, patient should, you know, but we ended up scoping the patient and he had a big ulcer that would have probably killed him. But again, they saw the patient, he was Black, he was homeless. It was like nobody thought he was worthy of the workup that he really needed. And we ignored the big things. We ignored that his hemoglobin dropped 6 units, mostly because we saw a Black homeless man that we did not think was worthy of our time and our effort to do what we need to do. And you know, this is something that I tell everybody. I'm like, irrelevant of what the patient will agree to, you have to do your due diligence. And it doesn't matter if you think about compliance, it doesn't matter if you think about their social family, none of this matters, because we still have to do our due diligence every single time, because we cannot let our biases influence the way we practice, right? And, you know, again, this was demonstrated in history time after time, demonstrated in our modern day practices. And therefore, you know, we need to take a step every single day. And, you know, when we're confronted with a situation where we feel like we're deviating from the standard of care because we feel something, I think we should keep our feelings aside and continuously always do the right thing and do our diligence all the time. So if anybody has any comments, we'll move forward. Okay, here we go. Okay. So we all discussed this here for a while. So I guess the closing remarks of this. So what can we do, right? You know, this is all great, but how can we be better, right? And, you know, we become better by having more discussions about this. We become better by understanding our own biases and understanding how to confront them as opposed to shy away from them, right? Because nobody wants to talk about this stuff. It's uncomfortable, it's this and that. But the more we understand it, the more we understand ourselves, the better care that we can deliver. It's really important to link people of color to like doctors, right? Because clearly they do a better job than people, you know, of not the same color. And I think this applies to many ethnicities. I mean, this applies to many people who speak other languages. You know, Spanish patients going to Spanish doctors. It's just better. It's better communications. It's better, you know, less cultural barriers. It's just better for everybody, right? It's more humanistic, right? Same thing. The same rationale should apply to Black patients. Black patients do better with Black doctors. Unfortunately, there aren't that many Black doctors. So this, this is something that we should, be thinking about when we're recruiting doctors. This is something we should be thinking about when we're recruiting doctors into medical schools. We should be thinking about the criterias, when people talk about, and this, a little off topic, but when people talk about affirmative action and people get very uncomfortable, they're like, oh, affirmative action means like you're less smart, but you're gonna go because you're Black. And it's like, you know what, even if that's the case, which is not, the fact that we have these issues tells us that we need way more Black doctors than we currently have. So if we have to resort to things like affirmative actions, that is the right thing. This is why these things were done, to correct what has been done in the past. So people need to just be a lot more open-minded about this, because we clearly have a lot of catching up to do to get to be in a place where we can treat patients really equally and fairly. And obviously the other thing is, looking at a lot of these algorithms and understanding if race truly needs to exist in the checkboxes of them, as opposed to not, and and give doctors that are interested in this type of work the time and the respect that they deserve. We focus a lot of our efforts on clinical, research and QI and this and that, cardiology, oncology, when in fact this is all great, but if we're not really doing the work that if we're not really doing that work to everybody equally and fairly, then everything that we do is really useless if we're not delivering the care that we think we should be delivering. So this type of work should be emphasized. It should be highlighted. It should be encouraged, and people should really should be allowed the time to do this kind of work in institutions, particularly like the place where we are, because we do work in an underserved area with many patients and underrepresented populations. And we talked about this. Sinai has removed, like I said, the African American race from the GFR calculator, so that's great. And it sounds like they removed the statue of the father of modern gynecology from their medical school, which is wonderful. I mean, it's had to be done. And the final take-home message is that our Black patients are a compromised group of individuals, and their care must simply improve. We just have to do better. We simply do. We have unintentionally marginalized many, and we continue to use stereotypes to practice medicine. So we need to always be cautious of that. We have to, we really have to confront our inherent biases and do a better job at not have as many of them, or at least acknowledging them, understanding them, and doing the right thing. And, I think when people is like, oh, well, there are other minorities, other groups that need a lot of effort. Yes, that is all very true. But again, statistics, time after time, statistic after statistics, we give the worst care to our Black patients, probably followed by our Native Indian patients or Native American patients. So just something to think about for many of you. Hopefully we'll have your own practices, and just day to day, we just have to do better. And with that, I conclude. And then to answer the question, I even forgot. To answer the question, hopefully you guys thought about it in your head. And obviously the answer to this question is no. Black patients do not have thicker skin than white patients. Simply, they don't. However, at UVA, University of Virginia, they decided to do a survey of patients, residents, medical students, and believe it or not, 58% of regular people thought Black people have thick skin, and 25 to 42% of medical professionals did too. And I wouldn't be surprised if all of us the same, 50 or whatever, 30, 20% of us thought Black patients have thicker skin. They don't have thicker skin. They have regular skin, just like all of us. But again, why do we think that? I don't know. Why do we not give pain medicine? I don't know. So many things that go into it, but this is real. This is happening. We are all part of this, and we just have to educate ourselves better, and we have to do better. We simply just have to do better. And with that, I end.
Thank you so much, Dr. Shihadeh. Just one quick question. I'm sorry if I missed it, but did we address Kirtana's question? She was just wondering if you were aware of any evidence in terms of different rates of litigations between different patient races.
Dr. Shihadeh, I just wanted to ask why I asked that question. I was just thinking about why the standard of care that we deliver is different. I'm thinking unconsciously are, medical providers less scared of consequences if they were to miss something? Like, that's just one thing I was thinking of.
Oh, I see. I haven't looked into it. Like, why is it that we're just doing worse care? I don't know if it's a litigation thing. I mean, I think when you think in litigation, I think we're thinking, again, this is our bias here too. We're thinking that majority of our Black patients are poor, right? They're not going to sue us because they're poor, which is obviously not true. I mean, we just happen to work in an area where the majority of the Black patients that we see are poor, but that's probably not, not likely for if you go to a different suburb or a different city or, somewhere else where there is a larger portion of affluent Black patients, but, it's unfortunate that we don't see a lot of them. But if there's, I have not looked into that, no. But, again, why do we do worse? Yes, do we think that we can get away with it? Maybe. Do we think they're not worthy of the care? Maybe. Do we think they have thicker skin and therefore they need less pain medicine? Maybe. Right? I mean, it was a simple question. Do you think we have thicker skin? And still about 30% of medical professionals thought they had thicker skin. I mean, 30% of us are treating patients that they have thicker skin. You need less pain medicine. Your chest pain is not as valid. This is not as valid because you look different, then you are different. Therefore, your care has to be different. But litigation-wise, that I'm not aware of.
Thank you. I hope we can do better.
Yep, I hope so. I really hope so too. I hope so too. Oh.
Thank you so much, Dr. Shihadeh.
You are welcome.
For being here and having the great lecture. The lecture will be recorded and uploaded, and we'll miss you. Just
I know. I already miss everybody. It's been tough. It's been tough. It's very emotional few days for me. I really genuinely already miss everyone. But I will put it here. My email address is available. Many of you already have my phone number, which again, text me, email me, call me. I'm always available. But yeah, take care, everyone.